Greetings to all. I am delighted to take the next few minutes to present this case we've named Saving Private Ryan, emphasizing the significance of family ties. I'm Francisco Calvo, a clinical cardiologist at the Álvaro Conquero Hospital in Vigo, particularly dedicated to aortic and valve pathology. I am presenting the case of a 29-year-old man who has been followed up due to a family history of aortic dissection. The family background essentially indicated that his father passed away at the age of 38 due to aortic dissection. I will present the images related to this case right here below. His father's sister also died young from the same reason, and both of his paternal grandmother's brothers died young as well. They too passed away at young ages for the same cause. He was a patient who smoked, and we had been monitoring him for several years. In the year 2012, a genetic NGS panel had already been performed that included the main known aortic pathology genes. Fluidylin-1, genes associated with Lloyd-Stitch syndrome, ACT2, and others, all returned negative results. From the perspective of physical examination, it was notable that he was a tall, obese patient, but without any signs of hyperlaxity. He exhibited only abdominal striae, and as a curiosity, his uvula appeared normal. From the imaging technique's perspective, this patient had mild dilation of the aortic root, with some discrepancy between measurements by echocardiogram and MRI. The echocardiogram showed 41 millimeters, while the MRI indicated 45 millimeters. During the visit in November 2019, we decided to review the genetic study conducted 7 years earlier due to a notably positive family history. In this genetic study, we found a presumably pathogenic mutation in the SMOS3 gene associated with type 3 Lloyd-Stitch syndrome. This mutation caused a change in the amino acid at position 287, replacing an arginine with a glutamine. Using this information, we assessed the current aortic dimensions through multimodal imaging techniques. On one hand, the echocardiogram shows a root of 43 millimeters, but it is a very asymmetric root, and the double oblique measurements from the CT scan indicate that we perfectly illustrate how the root measures 51 millimeters from the middle of the right sinus to the middle of the left sinus. In other words, over 6 years, we observed a growth of about 6 millimeters. With this data, a very dilated root of more than 50 millimeters and the diagnosis of type 3 Lloyd-Stitch syndrome, we decided to proceed with the first step, which was to indicate aortic root repair surgery. It was performed using a Davis technique, and the immediate result of the intervention via transesophageal echocardiogram was excellent, with a coaptation height of more than 5 millimeters and without residual aortic insufficiency.
They were brothers. I just found out that this afternoon their mother will receive the 3 telegrams. And that's not all. There is a 4th brother, the youngest. He was dropped by parachute with the 101 on the eve of the landing. He is somewhere in Normandy. Is he alive? I don't know.
Well, I haven't allowed the license to show you this clip from the movie Saving Private Ryan, but it somewhat illustrates what was happening in our family. There is still someone else, and there is another person alive. And indeed, in this family, there was his grandmother, his paternal grandmother, whose 2 brothers had died prematurely and who had lost 2 of her 4 children. So he would be therefore our particular Private Ryan. Our second decision, therefore, was to rescue our particular Private Ryan, who was a 74-year-old woman and was undergoing treatment with irbesartan. She was part of another healthcare area, and in the first echocardiogram we did, she had a very dilated aortic root measuring 52 millimeters with moderate aortic insufficiency. A CT scan was also performed, which graphically showed us how the dilation of the aortic root was very asymmetrical, especially on the right coronary sinus. It also presented a bovine trunk. The coronary arteries exhibited significant tortuosity, and the aortic valve did not show any degenerative signs. Thus, we recommend aortic root surgery via the David technique, successfully carried out without complications and yielding excellent outcomes, as shown by the intraoperative echocardiogram images. The family study has yielded the following results, which I will present next. On one hand, we have 4 fatal cases, the 2 discussed patients and the 2 children of our soldier Ryan, along with 3 patients with manifest disease still alive. This includes the index case, the grandmother, and a middle-aged man with a cerebral aneurysm who is currently undergoing surgery, along with 5 cases without manifest disease that will be monitored over time for their life. In summary, we have a familial syndromic aortic dilation corresponding to a SMART3 mutation, type 3 Loeys-Dietz syndrome, in which we have presented 3 affected patients, 2 with aortic dilation who have undergone aortic root repair surgery, 2 patients with aneurysms in the intracranial arteries, plus we have 5 more patients. At the moment, they are not affected but are candidates for close follow-up. As for the progress of our index case 5 years post-surgery, I want to mention that he remains symptom-free, does not smoke, and his blood pressure is managed with losartan and bisoprolol. He has had to change jobs due to the special conditions of his previous work, and the outcome of the surgical intervention on the valve is excellent. He remains free of aortic insufficiency, and the diameters of the native aorta are normal at all levels. However, as part of the exploration for involvement in other territories, we have found an aneurysm in the anterior subdivision of the left middle cerebral artery that is under close monitoring due to its neurosurgical nature. As final messages, I would first like to briefly mention the Loeys-Dietz syndrome type 3E. The description in literature is quite recent. This publication by Van der Laad refers to 3 Dutch families that exhibited, in addition to aneurysms and dissections at a young age, a high frequency of osteoarthritis at a young age. For this reason, the initial description referred to it as the aneurysm osteoarthritis syndrome. Currently, we understand that osteoarthritis is not exactly a defining feature of this syndrome. We also know today that this syndrome is significantly important, and at least 5% of Loeys-Dietz syndrome cases are due to mutations in the SEMAS3 gene, are associated with mutations in the SEMAS3 gene. On the other hand, I would like to emphasize that the diagnosis of Loeys-Dietz syndrome involves a greater severity of aortic events than Marfan syndrome. It highlights the significance of intervening at smaller aortic diameters and the necessity for more rigorous follow-up using imaging techniques. Keep in mind that for our patients, due to unique circumstances, surgical recommendations were made at diameters exceeding those currently acknowledged. Finally, I would also like to include some concluding messages that I believe are sufficiently illustrated. On one hand, the first point is the significance of taking the time to compile a thorough medical history, particularly having good family medical records. The diagnosis of a case can represent the diagnosis of an entire family, and this deserves special consideration. Additionally, the current guidelines emphasize the significance of genetics in our understanding. It is undoubtedly useful on many occasions and will clarify many doubts. And on another note, we must remember the need to reevaluate genetic test results over time, as we have demonstrated in this case. Moreover, it is crucial to highlight the role of multimodal imaging in diagnosing and following these conditions, particularly the tomographic techniques for measuring asymmetric aortic roots, as illustrated. Lastly, it is important to note that extra-aortic involvement may be significant in Loeys-Dietz syndrome and is not limited to the aorta. But, as in the case we presented, the involvement of intracranial vessels can also be relevant. Thank you for your attention. Regards.